This is an LSU or the Lardell suction unit. Before using the unit, let's first make sure that all the tubing is in its place and that the battery seal is closed. When testing the unit, we must first take it off the wall to test the battery, hold down the test button, turn it all the way to full, and include the pipe. We know that it has passed the test when it reaches the top and it turns itself off. This must not be used in a moving vehicle and not for longer than 10 seconds, only going in as far as you can see. As you can see, the unit has passed the test, so we can now turn it off and it is ready for use. Possible risks of using a suction unit is induced vomiting, laryngospasm, bradycardia because of stimulation to the vagal nerve, soft tissue damage, hypoxia, and aspiration. When using the unit, we must turn it on to full, only go in as far as you can see, performing circular motions, and only including the hole on the way out. This is an OPA, or a oral pharyngeal airway. It is used to maintain the airway of a patient who cannot maintain their own airway. This prevents the jaw from clenching shut, the tongue falling onto the roof of the mouth, and it also allows us to use other airway adjuncts and suction around it to ensure the airway is maintained clear. Complications of using an OPA is possible soft tissue damage. It can induce vomiting if the OPA is too large, and it can also obstruct the airway further if it is inserted correctly and it catches the tongue. Contraindications for using an OPA is if the gag reflex is intact. Indications for using an OPA is a lower GCS, incomprehensible sounds in response to pain. Now, to measure an OPA and make sure it's the right size, you measure it from the corner of the mandible to the corner of the mouth. As you can see, this fits our patient. We are going to start off by putting the patient into the head tilt chin lift position. Once the patient is in that position, we're going to open the mouth, insert it halfway, and then we're going to rotate it 180 degrees and insert it the rest of the way. This is an NPA, or a nasopharyngeal airway. We use this in patients who have trismus and their jaws are clenched shut, or if they have a higher GCS and cannot tolerate an OPA. We measure an NPA by going from the corner of the mandible to the corner of the largest nostril. This fits our patient, so we are going to lubricate the NPA using water-based lube, ensure the patient is in the head tilt chin lift position, and we will insert it at 90 degrees to the patient. We then push it all the way in. If we meet any obstructions, we can rotate it 180 degrees, then push it the rest of the way in. It is in position once the top of the NPA is flush with the rest of the nostril. Benefits of using an NPA over an OPA is this does not induce vomiting, and this can be used with a suction unit to suction the airway, and this can also be used in a wider range of patients because a higher GCS can tolerate this. Complications to using an NPA is soft tissue damage, epistaxis, nasal polyps, as well as bleeding. Contraindications for using an NPA is base of skull fracture. Kind of cool. I'm going to be taking your heart rate, your respiratory rate. I'm going to take a blood pressure, which will involve a tight cuff on your arm, and I'm also going to auscultate or listen to your lungs. Listening to your lungs will involve listening to the front and back of your chest, and it may involve going up your shirt. Is that okay?
That's fine.
Okay. So I'm going to start off with your pulse. At the end of the 15 seconds of counting a pulse, I'm also going to count for 15 seconds a respiratory rate. This is because if I make her aware that I'm counting her breathing, she's going to subconsciously change her breathing, and this may alter the result. So I got 15 beats over the 15 seconds. If I times that by 4, that is 60 beats per minute. This is well within the normal range. I also got 4 breaths over the 15 seconds. So if I times that by 4, it's going to be 16 breaths per minute, which is within the 12 to 20 normal range. Now I'm gonna take your blood pressure. Is that okay?
Yeah, that's fine.
So I'm going to palpate blood pressure first to make sure I know where to pump it up to when I auscultate. So I got systolic at 110, so I'm going to pump it up to 130 when I auscultate. I'm going to release it slowly to make sure I don't miss the diastolic. So I got 110 by 70, which is well within the normal range. So I'm now going to have a listen to your lungs. Is this okay?
Yeah, that's fine.
Okay. So I want you to breathe in through your mouth and breathe out through your nose. Just going to go up your shoulder. So both sides of the lungs were clear and equal, and I could hear air moving in or out. There was no crackling, no stridor or wheezing. This patient has a lower arm fracture. We're going to use the plus discs acronym and compare it to the other arm to try to have a look and assess the injury. I'm going to have a feel along the arm. Is this okay?
It's fine.
This may cause some pain.
Ow.
Okay. I'm just going to check your pulse on both sides. And capillary refills. Capillary refills are both equal. Pulses are equal. Can you feel any tingliness, so everything still feels the same?
It's just normal.
Okay, so we can see some swelling, some pain, and a bit of deformity. So we're gonna go ahead on the basis that this is a fracture. So, do you have any allergies?
No.
No? Okay, and what's your pain like?
It's probably about a 7 out of 10.
Okay, so to help with the pain, I'm going to give you paracetamol. Okay.
Yep.
So paracetamol will last up to 4 hours, and it will take it roughly 20 or 30 minutes to come into effect. Now, have you had paracetamol in the last 4 hours?
No.
And do you have any current paracetamol poisoning?
No.
Okay. So, 2 500 milligram tablets.
Yep, so 500 milligrams paracetamol and expiry date is 09/19.
Okay. So, it's going to be 2 tablets. Could you just take those for me? Cool. So, I'm also going to give you 3 mils of methoxyfluorine. Okay. So you use this by putting your hand into the little bracelet, and then you breathe in and out through this mouthpiece. Okay.
Yeah.
So methoxyfluorine cannot be used if you've had this within the last week, have you?
No.
No? And do you or your family have a history of malignant hypothermia?
No.
No? And do you have any renal impairment?
No.
Okay. And could you just drug check this for me?
Yep, so methoxyfluorine and expiry date 2020.
Cool. So, this is very quick acting, and to use it, you just breathe in and out using the mouthpiece. If you need more pain relief, then you can continue to breathe in and out, okay? So you just put your hand into the, that's it first, and then breathe in and out. So what we're going to do now, while you have some of the methoxyfluorine, is that we're going to put your arm into a splint.
Yeah.
So this is going to involve my partner helping me, holding your arm on both sides, lifting it up, then we will place your arm into the splint, where we will then bandage it on either side of the fracture to immobilize it. Is this okay?
Yeah.
This is going to be painful, however, so you do need to keep breathing and using the methoxyfluorine.
Okay.
So I'm gonna put a towel in the cardboard splint to make it soft, and lift it up and down, and could you just hold the splint here? Thank you. we're gonna try and bandage it as tightly as possible on either side of the fracture. We're going to do the distal side first, and then move on to the proximal side. And I'm now going to do the distal side do it on the distal side of the fracture. Okay, just place the arm down. Thank you. So now that we have immobilized the arm, we are going to do neurological and cardiovascular checks on either side again. So I'm just going to take his pulse. But the sides are strong and equal, so I'm going to also do capillary refills. The sides are equal. Can you still feel the same? Still feels the same. There's no tingliness.
Just normal.
This is the C-spine collar. This is used to immobilize the neck in cases of suspected cervical spine fractures. However, this only immobilizes 50% of the movement, so further support is needed. To adjust the collar for use, you can push the locks out on either side and then adjust the collar like so. You can push the locks back in to lock it back in place. To assess whether a patient needs a collar, you should use the nexus rule. The nexus rule indicates that if there is any midline C-spine tenderness, evidence of intoxication, if there is an altered mental state, distracting injuries, or neurological defects, then a collar should be used. This, in combination with the Canadian rule, which judges the mechanism of injury to see whether a C-spine injury is likely. Now, this patient here was in a motor vehicle accident that was at speeds of greater than 30 kilometers per hour. So the Canadian C-spine rule and the nexus rules, because there's C-spine tenderness and evidence of intoxication, meaning that we should in fact use a collar on this patient. To place a collar on a patient, you must first make sure the head is immobilized. You can do that by getting the offsider to place their hands on either side of the head to immobilize the neck. They should then lift the head up, so then you can place a towel underneath the patient's head to place the head into neutral alignment. Once that has been done, you need to size the collar. You can do that by measuring from the top of the trapezius to the bottom of the mandible. As you can see, this is the right size for the patient, so there's no need to adjust it. We will now lift the head up and slide the back of the collar underneath and fold it over and strap it into place using the Velcro. Lift it up. Once the patient has the C-spine collar on, we can then move them onto the stretcher, and once it is on the stretcher and ready for movement, we should use tape and towels to fully immobilize the neck, as this only reduces 50% of the movement. This is my bleeding control. There are two ways to stop bleeding: direct or indirect pressure. If the wound is small, then you can just use an adhesive bandage to stop the bleeding. If the wound is big, you could use direct pressure, and you could wash the wound out using saline if it is dirty. If the wound is deep, you could pack the wound with moist gauze, and once you have done that, you can then use a moist dressing that is appropriately sized for the wound. Could you just hold this here? And then apply direct pressure using a bandage to hold the dressing in place. To tighten the bandage and put extra pressure, you could add twists into the bandage as you are going over the wound. Once we have done this, we can also place a second combine and bandage over the top to ensure if the blood is soaking through. Another technique to slow the bleeding would be using indirect pressure on the brachial artery, as well as using another bandage underneath the armpit and getting them squeezed down onto it to cut off circulation. Once we have placed the dressing, we should do a neurological and neurovascular check, checking the radial pulse on each side, capillary refill, checking to ensure it's the same, checking to see if there's any weird tingliness or change in feelings. No? Okay. So this is a tourniquet. If dressing the wound with bandages does not work, or if it is catastrophic bleeding, then we can use this. A tourniquet is painful, however, so we will need pain relief. To apply the tourniquet, you should only apply it on single buttoned limbs and tighten it. Once it is fully tightened, you should turn the windlass until you can no longer feel a distal pulse. Once you can no longer feel a distal pulse or the bleeding has stopped, you can then put it into the holder and document what time you applied it. If this still does not work, you can place a second tourniquet proximal to the first to stop further bleeding. The tourniquet should be placed within 10 centimeters proximally to the wound. Pocket B is the end-tidal CO2 monitor. This is attached to the back valve mask and measures the end-tidal CO2 volume of a patient. D is also the SpO2 monitor, which measures the oxygen saturation in a patient, and D will be the 4-lead ECG, which will give you 3 different views of the patient's ECG. In the back pocket here, there will be a non-invasive pediatric blood pressure cuff and a non-invasive adult blood pressure cuff. This here is the non-invasive blood pressure cuff button, and you push that to inflate either of the cuffs when they're plugged in. And the right side there is a 12-lead ECG, a test load, the defib cable, aspirin, shears, and GTN. In the back pocket, there is printer paper, ECG pads, and defib pads. And if we lift this up here, we can have a look at the batteries. You push each button. You push the button on each battery to see how much battery there is and see whether that is enough for use. I'm happy with the amount we have for now, so I'm happy to go on to the test. First of all, check the printer paper. You lift this flap up here, and you can open it to see how much paper you have left in it. To turn it on, you hold the green button down, and it turns itself on. To turn it off again, you hold the green button down to turn it off. It starts off in the automatic mode. Change it into manual mode, push energy select, use the speed dial to select, and push it in to select. We want it at 50 joules, so we'll select it at 50. We now want to run the self-test. So you push options, go down to user test, and select. We'll now run the self-test. So as you can see, the user test has passed. It has today's date and time. It also has the defibs number on it. So we're now going to do a test shock. So we push charge to charge the shock up, and then we can push the shock button at any time once it is making the noise to shock the patient. We have 30 seconds before the charge self-disarms. So push shock, and the patient is shocked. If, however, we do not want to shock, we can push the speed dial button to cancel it and disarm at any time, and this will not shock the patient. To change the lead views, we push the lead button, scroll down to 2, 1, and 3, and we can view the different leads from here. To increase their size, we can push the size button, turn it all the way up to 4, all the way up to a quarter of the normal size. We'll just leave it at 1 for now. To turn up the QRS volume, we scroll until we bring up the button, select the heart rate number, we push again, and we can turn it all the way up or all the way down. We push options twice to get out of the menu. As we approach the patient, we're looking for any dangers, electrical equipment, aggressive bystanders. There is none. We both have our PPE on, so we're good to go. So just place equipment down next to me. Hello, sir, can you hear me? Looking for a response. There's no response to pain or voice. I'm checking the airway. The airway appears clear. Now listen, feel, and look for breathing. There's no breathing, so start CPR. AUT1 to comms. AUT1, go ahead. R49 confirmed, requesting R50. So I'll just work around you. You just keep doing CPR until I tell you to.
Analyzing
Stop CPR.
Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock.
Stand clear.
The orange button.
I'm looking to make sure these are touching the knees. Start CPR.
Start CPR.
So I'm setting up the bag valve mask now. I'm going to insert the OPA. I'm also going to put a towel underneath the head to ensure a head tilt chin lift. I'm using the CNE grip, and I'm ready to ventilate. So once you reach 25, count 25, let me know and I'll ventilate. We're doing 30 to 2.
24, 25, 26, 27, 28, 29, 30.
Let's do chest rise. So I'm going to turn my oxygen cylinder on, switch it to 15 liters per minute. This will deliver 100% oxygen to my patient. I'm also going to set up my suction to ensure it is ready.
29, 30.
Good chest rise. So I've got my equipment next to me in case I need something else. I've got my suction unit ready and I've got oxygen flowing at 100%. So we're giving him 100% oxygen. At this point, I would look for bystanders, try and figure out the cause of the cardiac arrest. Good chest rise. So I was looking for the cause of cardiac arrest. If I cannot get good chest rise, I would also be using the MONES acronym, checking the mask seal, seeing if it's a VCD or the obstruction the cause of it. I would be looking at the age, see if they have teeth, see if their neck is still mobile, and whether there's any stiffness or sores. We are still getting good chest rise though, and could you speed up compressions a bit? It's good depth though, and it's a slightly more release. Yep, it's good.
Stop CPR.
Alright, so we're going to swap up, so stand up and walk around, and I'll just swap and take over for CPR.
Analyzing heart rhythm. No shock advised. Pause.
So I'm going to start CPR. Could you passively ventilate, please? Ready? This is my bag valve mask demonstration. This is the bag valve mask. You assemble it by extending it out, attaching the filter to the valve, which then attaches to the mask itself. The reservoir bag goes in the back, and the oxygen tubing goes in next to it. Once the tubing is in, you should turn the oxygen cylinder on to 10 to 15 liters per minute, which will give it 100% oxygen. You should turn on the oxygen cylinder and then attach the tubing and listen for any leaks in the tubing itself. There is no leaks in the tubing, so we are going to test the valve and bag next. So you occlude the hole and squeeze gently. There was no leaks, so that part has passed. We'll then test the reservoir bag. We squeeze and inflate the reservoir bag to check for leaks, and as you can see, there is no leaks, so we are just going to reassemble it now. To use the bag valve mask, you must first measure it from the corner of the mandible to the corner you must first measure the OPA to the corner of the mandible to the corner of the mouth. You then insert the OPA upside down and push it in the rest of the way. The bag valve mask covers from the top and comes down towards the chin. You then should use a CNE grip to do a head tilt chin lift and squeeze gently. As you can see, there was chest rise. You should be ventilating every 5 to 8 seconds. This will supply the patient with 100% oxygen, and you should be ensuring that the reservoir bag is inflating adequately. If there is gastric inflation, your offsider can then use coracoid pressure on the trachea to stop gastric inflation. This is an oxygen cylinder. You can identify it because it is fully white or fully white with black stripe here. On the puller valve there is also one port and 2 pins, and it normally has a label saying oxygen. Now this is compressed gas, so whenever you place the bottle down, it should be placed on its side on the ground. You should also be careful in case you knock it, because it could explosively decompress. This does also support combustion, so in confined spaces you do need to be careful, especially when near combustion sources. And having any oil on your fingers can also cause it to ignite. Indications for use of oxygen is decreased GCS, respiratory distress or shortness of breath, shock, TBI, toxic gas or smoke inhalation, or stats below 94 or SVO2 below 94%. The first thing you must do when you start is have a look at the Botox seal. If it is missing or broken, then you should replace it. Now, to put the regulator onto the oxygen bottle, you should first line up the pins and ports, and then turn the handle all the way. Once it is in place, you should give it another quarter turn for it to be fully in place. So you should then turn on the pill valve and check to see how much oxygen you have. This one here is full, and if it is below 500, then it should be changed. So these are nasal prongs. These are used to provide a low flow rate supplemental oxygen. It gives roughly 20 to 40% extra oxygen, and normally when the oxygen cylinder is set on 2 to 4 liters per minute. So these are non-invasive. They can be used for long-term care. They can be used while the patient is vomiting, and as well as combined with other masks. So to place the tubing, you should place it from the front, wrap it around the ears, and then insert it into the nostrils. You should ensure that it is set on 2 to 4 liters per minute, and once you have finished using it, you should close the pillar valve first, and then ensure there's no air left in the regulator.